So welcome everyone to today's VMR. Good afternoon, good evening, wherever you are. We are so glad to have you. 35 people, that's a huge crowd. So thank you all so much for joining today's VMR. I'm here together with the one and only Rabih, and I have the privilege to discuss a case together with him and together with all of you guys. And it's so nice to see you all, a lot of familiar faces, but also a lot of new ones. So welcome everyone who came, and please raise your hand if it's your first or second time. We already met Aline, whose time it's for the first time today. So welcome everyone. And yeah, I would give the mic to Rabih. How are you, my friend?
I'm good. 3 times just for you, my friend. Thank you for calling me out on my repetitive behavior. I see a lot of new faces here today. I'm really excited to welcome you all to VMR. I'm glad that you're joining us. We love to learn about medicine, but I think the thing we enjoy more is each other's company and our shared love for it. So if you are joining us for the first time, please let us know through the chat, just so we get to know you better and can welcome you more personally into this community. Oftentimes, in fact, the majority of the time, we will ask somebody from the crowd to present a case. And so if you have a case, we'll lean on you to present. But today, we have a special occasion because one of our very own, Omaima, has a case for us. So Omaima, do you want to say a quick hello? And after that, we can jump right in.
Hi, everyone. Thank you so much, Rabih. And good luck, Sammy, for the co-discussion. I'm a new VMR team member, and I'm so excited to be presenting my second case at VMR.
And just to make all of you feel a little bit at home, because I know people from all over the world. So Sammy is in Austria, I think, unless he's traveling the world, which he sometimes does, having gone to Prague recently. And Omaima's calling in from Morocco, and I'm hanging out here in San Francisco in California. So we are a global community. There are people in Spain, in Guatemala, and Peru, and Brazil, in France, and Italy. So really excited to welcome you all. And in the chat, when you do introduce yourself, and Deborah's in Argentina, that's right. Please let us know where you're from. We would love to get a sense of where you're joining us from. All right, Omaima, take it away.
Yeah, it's our little United Nations. All right, let's get started. Our patient today is an 80-year-old man who presented to the ED for a fall, preceded by intense dizziness, and he also tested positive for COVID 3 days ago.
All right, thank you so much, Omaima. So I will take a crack at that. So we have an 80-year-old male with a fall, and he tested positive for COVID 3 days ago, and he complains of dizziness, if I heard that right. So first, now we have a chief complaint of fall and dizziness. What I learned from CP solvers in the last years is that dizziness is a very unspecific complaint. If you take the same doctor and go let him examine 3 different patients, and there will be a different result every time. So it's like flipping a coin, and the patients also have a hard time explaining what they mean with feeling dizzy. So always you have to ask 3 questions. Is the dizziness, is there any other symptom, for example, chest pain, dyspnea, headache, vision loss, something like that? And if you have another finding, you should focus on that, because you can get much more diagnostic clarity out of it. The second question is the dizziness constant or episodic, which makes us think about episodic dizziness, for example, like BPPV, for example, versus when it's like more of a constant, would be more like inflammation of the inner ear, for example, like vestibular neuritis, or also a stroke in the posterior circulation can present that way. And the third one is, I forgot, but Rabih for sure. Yeah, so, and when I think about falls, you always have to think about what do you need for standing or walking. And first you need your sensory input, you need your cerebellum to coordinate, and you need your motor output to like walk at everything. So any culprit in all of these stations can result in a fall. For example, if you have a neuropathy, you don't feel where you're standing, or when your cerebellum, you have cerebellar ataxia due to alcohol, for example, you can't coordinate this information. And lastly, when you have a motor issue, for example, you have a stroke, you have a lower motor neuron lesion, or you have a myopathy, those can all result in falls. So yeah, I rambled a lot. Maybe Rabih can give us more clarity.
Oh, no, I'm not rambling at all, my friend. I think you appropriately laid out the large schemas for each of these conditions. And I think that the only thing that I will do is to explain what I think most people would do in this circumstance and the assumption you would make. But we will always remain anchored in the visual that you outlined. But I think it really depends on the power of history taking in this instance for us to ask ourselves, how convinced are we that the dizziness caused the fall? Because as you just told us, this dizziness is a big schema and fall is a big schema. So you can walk into the situation and actually get paralyzed, not because of not being able to move, but because of so many different options that you could take. So the quality of your history gathering here will allow you to make many, to actually question the assumption of whether the dizziness is why he fell. And so you might talk to him and render some confidence and simplify the problem. And so if you do gain confidence, which I think we can assume some confidence because of one word that Umayma used. She used intense dizziness. And if the patient literally said to you, hey, doctor, I felt so dizzy and then I fell, you'd be like, oh, okay, you know what? Let's just say that you were dizzy and you fell because of the dizziness issue. And I think that the way you approach dizziness is actually very powerful because trying to ask the patient to tell you whether or not they're experiencing lightheadedness or vertigo is a futile exercise. This is not my opinion. This is evidence-based medicine done in the very great work where, as you said, people went and tried to convince their patients to choose one option or the other, and you can easily convince your patient based on how you're asking the questions. So that exercise is futile, but another one is very productive, and you shared that. But let me share a simple way of thinking about dizziness. So this is, I think, the most important part of the teaching here. Dizziness is a feeling. It is a feeling that is beget and brought out by the neurological system. And so the key question when somebody is dizzy is it an intrinsic, inherent neurological disease, vertigo, or is it neurological dysfunction as a result of an issue that perfuses or colors the brain? I feel dizzy because something is happening here. And the question is, does it live here, vertigo, or is it because of the stuff that supplies the function of my brain? What are the two things that are essential for brain function? Perfusion and sugar. So what is the differential diagnosis of dizziness? An intrinsic brain issue, vertigo, or the two fundamental things that keep the brain going: oxygen delivery through blood pressure or anemia, and glucose. How can you tease these apart? We'll deploy that schema when we get more data. But that's the key approach: inherent neurological issue, vertigo, or a extrinsic issue like perfusion or anemia. All right, Umayma, tell us more, please.
Upon further questioning, the patient confirmed that he felt that the room was spinning around him and he lost his balance and fell, and there was no notion of loss of consciousness. Concerning the past medical history, the patient has hypertension, diabetes, mellitus, and chronic kidney disease, and a MOPIS 1 arrhythmia not requiring any pacemaker or medical management. Shall I give you the physical exam?
Please.
Okay, the physical exam is within normal limits. The blood pressure is 130/80, and the only thing that is significant is a point tenderness on the knee where he fell, and a respiratory rate of 19. But the rest is within normal limits.
All right. Wow. Okay. That's interesting. So for the past medical history, we have a lot of cardiovascular risk factors. We have hypertension, diabetes mellitus, CKD, which all predisposed to like thromboembolism and strokes. So could this patient be having a stroke as an explanation for his fall and his dizziness? I think he could. I don't know. Was the neurologic exam also within normal limits, Omema?
The neurological exam was normal.
Okay, thank you. Thank you so much for the clarification. You can have silent posterior circulation strokes. You can do the HINTS exam to like differentiate between a peripheral cause of vertigo and the central cause of vertigo, which actually has a very high sensitivity for like detecting posterior circulation strokes, similar to an MRI. So that's something that I think each one of us should really look into, because it's like a very easily done test, which can have a lot of diagnostic value. So otherwise, another thing that came to mind is the COVID-19 infection 3 days ago. Maybe this could trigger like a vestibular neuritis-like picture that caused him to fall. That could also be a possibility. Otherwise, for the physical examination, we have a lot of pertinent negatives, no abnormalities in the cardiopulmonary exam, no neurologic abnormalities, which maybe makes a stroke less likely, for example, but I still wouldn't rule it out just because of its morbidity. Otherwise, I don't know how much I can do out of that information. I don't know, Rabih, can you help me out?
Oh my God, I need your help. Omaima, every single time Omaima presents, I get a little bit nervous because I'm shocked at this exam. And if you're not surprised, please teach me. Because I will let me make one point. Why does the problem of vertigo, cause dizziness? Why does one feel the room is spinning? Anyone know? Why do people feel like the room is spinning? Let me know in the chat, or Sammy, you can say it out loud, or anybody can say it out loud. Why do they describe that sensation that the room is spinning? Yeah, exactly, AMK. The problem with vertigo is that patients have abnormal eye movements. They have a dysfunction in their signaling that tells us that we no longer know where we are in space. And so our eyes are constantly moving. And it is that constant motion of our eyes while we are still that makes us think the room is spinning. And in fact, our eyes are spinning. So Sammy, we're trying to solve a dizziness problem with a normal blood pressure and no nystagmus. And this means we're dealing with an Omaima case. What is the hole? The hole is that the patient had transient hypoglycemia. That's possible because remember, perfusion, hemoglobin, glucose, neuro. Or the nystagmus was too subtle to notice. None of us are perfect. So the exam, just like a JVP, may be hard. Or we are dealing with an intermittent vertigo syndrome. I think by definition, a stroke would not be what we're dealing with now because the patient has no deficits. However, a TIA or a stuttering stroke is the most important differential diagnosis for intermittent vertigo. So Sammy, let's make an assumption. We know a patient's dizzy. We haven't ruled out a cardiac cause. We haven't ruled out anemia. We haven't ruled out glucose, but because the patient described that the room was spinning, we can start to coalesce our hypothesis around vertigo. And now the tension, as there often is when Omaima is teaching us, is we actually don't have vertigo. We have hyperacute episodic vertigo. And the reason we cannot make any progress on the mechanism is because the patient is normal. So you cannot do a HINTS exam on a patient who has no nystagmus. Cannot do it. The HINTS exam requires the presence of nystagmus and does challenging tests to understand the nature of that nystagmus. So Sammy, how do you think about episodic vertigo? Comes and goes.
Well, that's a very good question. I haven't thought too often about it, but when something is episodic, it makes me think about like for example, hypoglycemia that comes and goes, about electricity that gets activated. For example, if someone has a seizure, someone has arrhythmias, that could cause like an episodic pattern of symptoms. Yeah, otherwise I don't associate vestibular neuritis with an episodic picture. Also don't, there could be BPPV, which could be possible, but yeah, it just doesn't sound like it to me. Yeah, those would be my first thoughts.
Absolutely superb. So I don't normally do this because most of our schemas are now on behind the scenes on RLR CP solvers, but I wanted to share this one with you because we have so many wonderful new people here. So I think it's helpful to understand episodic vertigo and whether the episodes are constant or positional. So does the patient have recurrent episodes of vertigo only when they move, or do they have recurrent episodes of vertigo without any motion? It doesn't matter. Unfortunately, we don't know that in that patient because his initial episode was not witnessed by us. But look at the sheer number of causes here. BPPV, TIA, stroke, migraine, Meniere's disease, multiple sclerosis, Cojans. There's so many things here. So I think I'm showing you this to tell you that the most important question we need to ask now really is probably, unfortunately for the patient, to wait for this episode to return and understand it better. But I think we have to use the blood work to make sure we're not dealing with a cardiopulmonary glucose cause. And I think the most morbid thing, Sammy, is to relate this to COVID somehow. And the most morbid complications of COVID are vascular in nature. So what I would be doing in real life, honestly, is hoping that this would recur, not for the patient's sake, but for his diagnostic sake, getting basic blood work to understand and make sure we're not missing a cardiac or glucose hypothesis, and holding the possibility that there might be a COVID-related complication, including vascular disease. All righty, Jemima, tell us more, please. We're very intrigued.
Okay. So the patient's glycemia is 1.1. His hemoglobin is 8.9. The MCV is 74. The platelets are 150, and the white blood cell are 3,000. Should I give the remaining labs? Well, some of the remaining labs.
Jemima, do you mind telling us what the MCV again? I think it was low. Is that right?
74.
Okay.
And a repeat PCR test was still positive for COVID.
And the glucose was normal, you said?
1.9.
I think the units might be a little bit different from what we use. Do you know where that falls in the normal? Is that normal, or because 1.9 would be unmeasurably low here?
Okay, it's 190.
190. Okay.
Yes. Sorry.
No, that's hey. We all use different units all the time. It's not your fault. And I think, Sammy, the white count is 3, so 3,000 or 3, so it's normal. It's slightly low. Yeah. Okay, awesome. All right, what do you think, Sammy?
All right, a lot of interesting data. I always prefer labs over past medical history or physical examination because, in my opinion, it's easier for me to interpret. And here we have leukocytopenia and anemia, which is microcytic or microcytic, and low-grade thrombocytopenia. We could frame this as mild pancytopenia. I don't know how much diagnostic value we could get out of that. I would first look for previous blood counts to check if that's something new or that has been lingering in the back, for example, like as an MDS picture, which would more likely be macrocytic. But here we have like a microcytic anemia, which makes us all reflexive to think about iron deficiency anemia. There are other causes. Thalassemia would be odd in an 80-year-old male. But for example, lead toxicity, sideroblastic anemias, anemia of chronic disease could also present in that fashion. So first thing I would do, I would like to know if that's something new. If those lab abnormalities are new, I would definitely get an iron panel, get an CRP, ESR to check for inflammation. And the persistent positive COVID test isn't too surprising for me. It maybe increases the likelihood of all of that being COVID-19 related, which you already pointed out, Rabih. Maybe is there a thromboembolism going on? We don't have any signs of hypoxemia or tachycardia, which certainly don't rule it out, but there are also neurologic complications of COVID. You get demyelinating disorders. I don't know if we want to go down that rabbit hole, but also thinking about the vestibular system. And as you said, we have to catch it in the episode. But yeah, those would be my first thoughts.
I think that's absolutely superb, my friend. I have nothing to add except to say that, you know, when you see a microcytic anemia, you don't know exactly if it's iron deficiency or not. However, in all comers, iron deficiency is much more common than anything else. And in thalassemia, the microcytosis is proportional to the anemia. And for a hemoglobin of 9, you would expect in thalassemia for the MCV to be much lower, 60s probably. So I would guess that based on the risk factors for iron deficiency, namely his CKD and the base rate, and that the MCV is higher than it should be for thalassemia, that this is iron deficiency. And why does that matter? Because remember, iron deficiency anemia is a blood loss problem until proven otherwise. And the blood loss problem is chronic for it to show up as iron deficiency, but sometimes that chronic blood loss can suddenly take off. So I think my operating hypothesis now has changed. The patient's description is most prominently consistent with vertigo. However, the laboratory signature of a microcytic anemia evoking an iron deficiency anemia opens up a more morbid hypothesis that he has intermittent acceleration of previously indolent bleeding. That hypothesis may not bear out, but if you are taking care of this patient right now, that's what you should probably assume. So this goes to show you how hard medicine is, because right now with little data, you can be thinking of a stroke all the way here, or you can be thinking of a lower gastrointestinal bleed at the same time. And so you really need to keep a close eye on the patient to see what part of those hypotheses are going to bear fruit. All right, Amima, Mike, to you.
Okay, the patient's sodium is 134, potassium is 5.4, calcium is 11, and estimated GFR of 7 milliliters per minute.
Sammy, I think Amama's just going to do a slow sequential reveal. Okay.
A lot of teasing.
Oh my gosh.
Yeah, very interesting. Yeah, I think the labs are compatible with CKD. I mean, the hyponatremia and the hyperkalemia. I always think of adrenal insufficiency with that, but first you have to think about renal insufficiency when you see that. And here we have a past medical history of it, and maybe it got exacerbated by some pre-renal state, for example, and now it's like decompensated renal failure. So yeah, the calcium of 11, which is high, maybe most likely with CKD would be hypocalcemia, because you get decreased hydroxylation, vitamin D deficiency, etc. So this could make so we could open like the hypercalcemia schema and definitely get an PTH, but in this scenario it would assumingly be high, and because we have a cause of secondary hyperparathyroidism as a reaction to the chronic kidney disease. So I don't know how much diagnostic process we would make out of that. Otherwise, check for other risk factors for hypercalcemia, immobility, thiazides. I don't think he's on a thiazide. And also with the chronic, with the presumed bleeding and GI loss of iron, we could also think about malignancy and open the bucket of malignancy-induced hypercalcemia. Yeah, those would be my thoughts, I think. I don't know how to make much more progress out of that.
Yeah, I think it's, you're getting a series of data points that are increasingly more alarming. And what's alarming here, I think, is just how abnormal the calcium is, as you already pointed out. So, when you're hearing that the creatinine and the GFR are 7, you expect the calcium to be 7. And it's so abnormal. This is like a calcium of 15, 16 in somebody with a normal creatinine. So I think when you look at this, you have to get a little worried that there may be a misdiagnosis. And let me explain a little bit why. So, Sammy, as you said, the patient has CKD and not exactly, I just put it in the chat. I think that's the thought to have right now. The patient has CKD and does not have end-stage renal disease. And so while you can hypothesize that the patient has tertiary hyperparathyroidism, which means that chronic kidney disease / ESRD has induced a tertiary hyperparathyroidism, that is unlikely to occur in a patient with chronic kidney disease. And so if you think about it, you have anemia, you have hypercalcemia, and you have kidney disease. And that combination is very concerning for the possibility of a paraprotein-related disease. And then when you look closely and you see that there's a hematological fingerprint as well with the low white cell count and then and the anemia, you worry even more. So I think I'm worried that this patient has a paraprotein disease process. Now the question is, what kind of emergency can happen from this issue? And that's where we always have to go back to the chief concern, dizziness, right? Now that we have this hypothesis, go back to the chief concern, dizziness. And let me show you, now that we're just showing schemas galore today, why not? I'm going to show you an oversimplification that I said out loud, but should be in our dizziness schema. And we're doing it slow today. So there's a rare but important cause of dizziness. Remember how we said it's a neurological sensation, either intrinsic, vertigo, or extrinsic. We've talked nothing about the neurological system, and we keep talking about the blood, right? Anemia, hypercalcemia. What are the causes of dizziness from the blood? Yeah, we said hypoglycemia, we said anemia, but hyperviscosity, simply remembered by a high hemoglobin, but not necessarily anything that is concentrating the blood, can cause that symptom. So I think now, unfortunately, we're in a very tricky situation because we don't know what the patient has, but they could need very emergent treatment. They could hypothetically need plasmapheresis very quickly. So how do you think you would approach this concern in real life, Sammy? How might you address that hypothesis in real life?
Yeah, if I'm thinking about hyperviscosity, I'm thinking about, is it cellular or isn't it cellular? Here we don't have any clue that it is cellular, so we don't have leukocytosis or hyper like leukocytosis, for example, that happens with leukemia. And the other thing that you can also get like increased proteins in your blood, for example, with B-cell dyscrasias that produce M protein, for example, IgM or IgG. To be honest, I always associated hyperviscosity syndromes more with Waldenstrom's macroglobulinemia and less with multiple myeloma. And that's why I didn't immediately think about it. And I don't know if multiple myeloma can also present with hyperviscosity. I think it can. And we have a lot of evidence here that this patient could have multiple myeloma. He's an older man. He has anemia. He has hypercalcemia. He has renal insufficiency. So definitely get an albumin, get a total protein, check for the difference, for the delta gap. If it's above 4, that could heighten our suspicion. Also get light chains. You can also have light chain myeloma that won't build a gamma gap. So always think about that and get an electrophoresis with immunofixation. I think if we go down that route, I think I would do that and get a bone marrow.
Absolutely superb. I'll ask you a harder question now since you hit a home run on that one. I'm going to ask, pretend that this patient's hemoglobin was 5.9. How much blood would you give that patient? How much transfusion would you give that patient?
I don't think I would give him.
Yes, you didn't fall for the trap. Good, excellent. You know, I knew you would get it correct. That's why I took a risky question. But yes. And can you explain to everybody why you would not transfuse a patient with a hemoglobin of 5 with this hypothesis? What would be your thinking?
I'm not 100% sure on that, but I think it would increase the viscosity and cause more microcircular disturbance and less oxygen delivery and further deteriorating this whole process.
I would give you a standing ovation, but my desk is very short. I'll probably fall if I stand, but that's absolutely right. I think you have to ground yourself in reality. In reality, it's actually tricky to do this in real life. I think it's important to any time that you think that the patient has some paraprotein, either triggered by anemia, triggered by CKD, or hypercalcemia. In this case, we're lucky that we have all three. Whenever you have that thought triggered, you have to immediately change your normal practices. And that would be to not transfuse a patient. Now, I think conceptually, people are in the chat are already far ahead and wondering if this hypothesis is correct, and we don't know that. Is this more likely Waldenstrom's, or is this more likely multiple myeloma? And I think that people are correct in saying that hyperviscosity is much more likely to be from an IgM-mediated process like Waldenstrom's. And that's possible. However, hypercalcemia and kidney dysfunction is not a common feature of Waldenstrom's. Waldenstrom's usually causes organomegaly, causing cytopenias, pancytopenias, and hyperviscosity. In contrast, multiple myeloma disproportionately affects the kidney and disproportionately elevates the calcium, but typically does not cause cytopenias other than anemia. So if you're trying to guess, the things going for Waldenstrom's are the patient's leukopenia and the patient's presumed hyperviscosity. The things going for multiple myeloma are the base rate, it's more common, the hypercalcemia, and the kidney dysfunction. If I were a betting person, I think I would probably go with multiple myeloma so far, because leukopenia can be seen in up to a third of patients, but either one is fair game. All righty, Omaima, tell us more, please.
Okay, so the total protein is low. There is no M spike on the SPEP. And we did an X-ray of the patient's knee, and it revealed osteoarthritis and a lytic bony lesion in the lower part of the femur. And the peripheral blood smear is normal.
Wow. Okay. So we talked 10 minutes about multiple myeloma and Waldenstrom's just to find out that there's no M protein. But yeah, that's what makes medicine so interesting. So I'm completely humbled by this case. So you said there is an osteolytic lesion at the femur?
Yes, at the lower end of the femur.
Okay, thank you so much. Yeah, I think osteolytic lesions reflexively make me think about like a plasmacytoma or other metastases of solid cancers. I still would like, I know that you can measure the serum viscosity. I don't know if you can get hyperviscosity due to light chains, only due to light chains. Yeah, I would definitely want to get maybe a CT of the brain, or maybe also an MRI to check for central causes, and get an iron study and maybe do an endoscopy if we find something there, to check for GI malignancy. Yeah, but otherwise I'm a little bit lost, to be honest.
Hypercalcemia, bone lesion, anemia, and kidney disease, and it doesn't turn into multiple myeloma or paraprotein disease. Oh my gosh. The truth is that you have to be careful, because testing for paraproteins is not perfect, especially in patients with kidney dysfunction. So when can the most common workup is to get an SPEP, immunofixation, and serum-free light chains. That gets you the answer 90% of the time. However, in some circumstances, especially AKI, these tests perform less well, and you need these additional tests. So Where am I at? Sammy, I'm right there with you. I see that you pivoted completely away from this, and I think that's wise. We have to recalibrate our hypotheses, as has been the case throughout this conversation, constantly recalibrating with more information. In real life, I think you should think about hyperviscosity and continue to think about it until proven otherwise. However, the normal total protein makes Waldenstrom's much less likely, much less likely. It's usually associated with a high total protein. So I think we can constantly recalibrate this conversation, but I think I wouldn't move totally away from a protein hypothesis until the serum-free light chain and the UPEP results are back. And if they're not obtained, that's okay. It'll continue to hold that. But now we can reframe this case and say we had dizziness, we found leukopenia, microcytic anemia, hypercalcemia, and kidney dysfunction, and now we have a lytic lesion. The most easy approach is to think of the lytic lesion, which, and if you're approaching lytic lesions in general, you should think of three things right off the bat. Is this osteomyelitis? There's no infectious symptoms. Is this malignancy, which is a conversation we're starting to have, or is this endocrine? And the devastating effects of hyperparathyroidism can cause lytic lesions everywhere and can cause this entire picture. In fact, this patient might have had chronic untreated primary hyperparathyroidism for all his life. And that might have resulted in hypertension. It might have resulted in CKD, which might have resulted in diabetes. The CKD from primary hyperparathyroidism is from calcium deposition in the interstitium. That then caused the anemia, and then the lytic bone lesion is as a result of the osteoporotic effects of PTH. So for me, I think if I were taking care of this patient, what I would do next is I would start with a serum-free light chain, a UPEP, and a PTH. And if those don't reveal the answer, then I think we have to focus on what kind of cancer this person has. But I still think my investment would be in the labs before anything else. What do you think about that hypothesis, Sammy?
Yeah, I love it. I think it's great. I would go with it too.
Okay, already. Umayma, tell us more.
Okay, for the next aliquot, the IgM of this patient is normal, the IgA is high, and the IgG is high. Free kappa serum is 7,000, which is very high. Lambda is 85, which is, well, slightly high. And we couldn't do the UPA because the patient, the nephrologist sent the patients for hemodialysis. I have one more test left and we'll be done.
So, Umayma, I'll summarize. The lambda was very, very high and the kappa was normal, or the other way around?
No, kappa was very high.
Kappa was very
and
high.
lambda was high normal.
Okay. And do you know if the rate is the ratio more than 100 or?
Yeah, the ratio is more than 1,000. 7,000 for free kappa serum.
All right, Sammy, you were vindicated, I think, but let us know what you're thinking.
Wow. I know that in chronic kidney disease, you can disproportional elevation of kappa to lambda because their particular endothelial system clears slower kappa and lambda, and the ratio depends more on which light chain gets produced more, and kappa gets produced twice as much as lambda. So usually the ratio would be 2 or something. If it's 1,000 or 100, I don't know. Would speak again for B-cell dyscrasia and make me think again about a malignant plasma cell dyscrasia. Yeah. And I know that IgA myeloma is, I think, very rare. I only know about it that it can cause an anion gap metabolic acidosis. I remember it with IgA and anion gap metabolic acidosis. That's all I know about it. But I think it could explain this clinical syndrome, also the osteolytic lesion, the anemia with the hypercalcemia. But yeah, I'm really, Rabih, I don't know.
I think, Sammy, it's very empowering to hear you say, I don't know, when you're talking about nuances of hematological issues. I think it just goes to show you, I think the lesson that I'm taking away from this is base rate is so powerful. We spent 10 minutes talking about multiple myeloma and hyperviscosity, and then we got a test that questioned that hypothesis. And I think the thing to do every time that happens is to make sure that you're calibrating the performance characteristics of the test according to your base rate. So if our pretest probability was low and the test was negative, stop. But we had 10 minutes of conversation, so the test shouldn't dissuade us. And so I think where are we now? when the capital lambda ratio is over 100, it's diagnostic of multiple myeloma. There's nothing else that causes such an abnormal issue. And so the thought exercise, the diagnostic thought exercise is, how can multiple myeloma present without a paraprotein on SPECT? And that is either because the test is imperfect, either because there's no immunofixation done, or there's so much accumulation of normal proteins from kidney dysfunction, or a special kind of immunofixation needs to be done to capture an IgD or an IgE multiple myeloma. So those are not usually done on the routine immunofixation. So what are the possibilities that are a problem with the test? We didn't do any immunofixation, or we forgot to do the IgD, IgE immunofixation, or the test is dysfunctional in the face of kidney disease. Those are the possibilities. The other possibility is the patient does not have a heavy chain component, and this is a pure light chain producing plasma cell disorder, which is possible. Practically speaking, I'm really glad that the patient got hemodialysis, because this will also help with the hyperviscosity symptoms that we got. But yeah, I think now with the lytic lesion, the hypercalcemia, and the capital lambda ratio over 100, you've diagnosed a plasma cell disorder on the order of multiple myeloma, which is really, really complicated for the patient because of just how advanced it seems to be. Yeah, Wema, tell us more. What happened to the patient?
So yeah, the last test was a bone marrow biopsy that revealed a plasma cells that revealed that more than 50% of the marrow cellularity were plasma cells, and it was indeed multiple myeloma. Great job, guys! You nailed it.
Well, Maima, that was an unbelievable form of storytelling. I'll ask you in a moment to tell us how the patient's doing and what happened, but you had us talk about vertigo and Hintz exam and bleeding and hypercalcemia. The conversation was so rich, and I think it's so evocative of how complicated medicine is in real life. You can't start with 80-year-old man dizziness and say, oh, multiple myeloma. There's a process that we have to go through, and I think you really let us have a really nice and very long conversation. What did you take away from this case, and how did the patient do?
The patient was seen by an oncologist on outpatient. He's doing well. I think the drug he's taking is called bortezomib. I'm not sure. I don't want to say something stupid. And yeah, he was doing well. What I learned is not to get fooled by a low total protein or an absent M spike. We were kind of reassured it's not since the total protein was low, but then the attendants told us that, well, he has chronic kidney disease, so like his proteins are not getting reabsorbed, so it makes sense. And if we had the opportunity to do UPEP, we probably would have seen very, very high proteins. Well, probably, certainly, we would have seen very high proteins. And yeah, I'm glad he's doing better, and I'm glad we got so many great teaching points out of this case.
Yeah, thank you so much, and thank you for sharing the learning you had along the way. I think it's the most important point in this case is when you're building momentum and you get one piece of disappointing news. If you have a lot of momentum, you got to keep going, but you should use the news you got to add some other things as well. Sammy, that was one of the toughest VMR cases to discuss, I think. It's not the most esoteric VMR diagnosis, no doubt. We've had more esoteric, but I think the way Omaima told us the story really made us, I don't know, I got some palpitations. How did you feel?
Yeah, I think I got 3 times the palpitations that you got. I haven't thought about multiple myeloma in a longer time. And yeah, it was a very atypical presentation of like of a not so rare disease, and I think we all learned so much from it. And Omaima, thank you so much for presenting it so precisely and each aliquot thoughtfully so that we could get the most out of it. Thank you so much, and I learned a lot, and I will read a lot after that.
Sammy, I'm so impressed by so many things that you do, but I hope that I hope you can take some specific feedback on how I feel in my extreme comfort in asking you a trick question on VMR in front of 40 people watching you. I've never done that before. I rarely do that, and only really do that when I feel like it is in a situation where somebody is so pushed to learn and grow that they don't really care if they get a trick question wrong. And so I admire your relentless pursuit of clinical medicine. It's very admirable, and I think discussing a case like this is and being able to do it is no small feat. So thank you. All right, Vale, take us home, please.
Thank you so much, Rabih and Sammy. This was an amazing discussion and a really great case. So we started with the chief concern of dizziness, which is very variable in terms of the description that the patient can give. So Rabih gave us an approach that differentiated it in two buckets: intrinsic causes, which usually points to a neurological diagnosis that is called vertigo. And then we have extrinsic factors, such as the blood, that this was the case today. And then Sami shared with us some of the questions that he asked patients with chief concern of dizziness, such as what are the associated symptoms, and if it's constant or episodic, or if it has a trigger, such as the position. Then we went to the HINS exam after the patient gave a description of what seemed very much like vertigo. However, the patient was not in acute vertigo, so we couldn't actually do the HINS exam. It would not be appropriate or useful. However, it is useful to increase the likelihood ratio of causes of central vertigo, such as a posterior fossa bleed. And these include the head impulse test, nystagmus, and test of skew. And then we have the approach to episodic vertigo, which was the case here. We have unprovoked versus provoked. However, then the labs showed us a different approach to the chief concern. We showed microcytic anemia, in which we have a lot of causes, including iron deficiency, which can be due to a bleed, or thalassemia, and Rabih shared a pearl, but I'm not using pearls for the emojis. I guess your pearls are so good that they are diamonds. And then, so the pearl was that in thalassemia, MCV is proportionally decreased with hemoglobin. So it was something that made, in this case, less likely. And then the fact that the patient had hypercalcemia, tertiary hyperparathyroidism will be rare, because even though the patient has CKD, it is usually more prominent in patients that have end-stage kidney disease. And then the patient ended up having hyperviscosity syndrome, which can be classified in three buckets: when something is wrong in the plasma, that's making the blood or the plasma more viscous, such as the presence of paraproteins or globulinemias. And then something wrong with the cell number, such as in patients with myelodysplasia, such as polycythemia, myeloproliferative syndromes. And then something wrong with the shape of the cells that make them clump together and kind of increase the viscosity, such as in sickle cell disease. And the last pearl, that is actually one that Rabih also shared in the last Saturday's VMR, was that in cases of negative SPEP that can happen, we should think about the possibilities of this happening in a very compatible case of multiple myeloma. So it's either that the test is imperfect, there was no appropriate immunofixation, or the fixation didn't include some immunoglobulins. And in that case, we should do a UPEP and serum-free light chains to maybe decrease the likelihood of this being multiple myeloma. So thank you so much for the case and discussion. It was amazing.
Superb, Valerie. I haven't heard you doing medicine teaching points in a long, long time, and I think you absolutely crushed it. Thank you. All right, I hope you had a good time. I'm sure you learned a lot. I know I did. And hope to see you next time. Bye.